Darwin Platform Group of Companies is one of the fastest growing diversified Indian conglomerates with global footprints. It is setting up offices globally and tying up with companies across the globe from multiple sectors. The company has ventured into real estate and construction, stockbroking and finance, arms and ammunition, mining, airlines and many other sectors.
Concerned over the wide variation in medical treatment costs and the difference between government and private hospitals in this regard, the Supreme Court of India has given the central government a month to fix standardized rates for different medical procedures. The top court has said Indians have a fundamental right to healthcare and the centre cannot evade its responsibility in ensuring this right. Understandably, the private sector healthcare industry is worried. Stocks of listed companies have fallen and reacted to this news. And the big question we are asking on the show today, can everything be priced at the same level in healthcare? Joining me on the debate on the issue of standardized rates and the likely impact on our healthcare sector, Dr. Ashish Chaudhary, the Managing Director of Akash Healthcare, a very noted orthopedic surgeon. Dr. Giridhar Gyani, the Director General of the Association of Healthcare Providers of India.
Yes, sir.
And K.K. Sharma, noted competition lawyer and the advocate for the petitioners in this case. I will have to start with Mr. Sharma to explain to our viewers the rationale behind this plea by the NGO. Why are you seeking to bring in price control and make it same for everyone? What is the logic behind this, Mr. Sharma?
As a matter of fact, as you said, whether the rates can be uniform. As the law does not provide the rates to be uniform for all the hospitals. It provides for the place, and therefore the rates have to be decided by the central government in consultation with the state governments. So the rates have to take the ground realities into applicable rules were notified in 2012. After 2012, the Rule 9 says that the central government, in consultation with the state government, will determine the rates of different procedures and different facilities. And those rates have to be displayed at these assessments. So the rates will be decided according to their status and the kind of facilities. So the rates are not to be imposed on a uniform basis. They will have a realistic groundwork. So the purpose is that as of now, we saw during COVID how everybody is arbitrarily charging the rates. So these rates have to be reflect the ground reality. The only difference is that they do not eliminate the private hospitals to make profit, but the only difference is that they do not want to encourage them to make profiteering. So the petition says that this law, which has been there on the statute and is available from 2012, even after a passage of more than 12 years, it is not being implemented. The only prayer of all that it should be implemented.
Okay.
Because our central government is starting from 2020, when the petition was filed, till date, has always sought time. They said this, and then we just on this last date, we presented an alternative remedy that lordships already some rates which have been decided following the same consultation process are available in the central government. They are CGHS rates. So in case they are taking time, not a problem, till they decide any different kind of rates, CGHS rates which are available for different cities, taking ground realities into the entire equation, can be treated as a default rate. And once the central government comes up with a different rate, they can switch over. So that's what they said, that before the next hearing, you do not come up with after determination of rates, so let the CGHS rates be the default rate. So that is what the Supreme Court said on the last hearing.
Fair enough. You've litigated and been involved with competition law for years, Mr. Sharma. And while that has logic, I have to ask you a follow-up question quickly before I go to the other guests. why,
Right. It's
why,
a matter
why,
of
why would the choice be taken away in that sense of forcing a standardized rate in the manner that you explain across different levels of service? Two hospitals cannot be the same. Two doctors are also not at the same level. A senior consultant may be very experienced, 20 years, 30 years, he'll obviously charge for more. How would you make this standardized work? You know, you go to a 5-star restaurant, you pay a different rate. You go to a roadside eatery, enjoy that food, you pay a different rate.
absolutely.
Okay, I think we are having a bad network with Mr. Sharma, but as he comes back, I want to take that very question to Mr. Dr. Girdhar Gyani first. Dr. Gyani, is the Supreme Court reflecting the frustration of Indians who feel overcharged and fleeced at certain places in the private sector, where all manner of misuse in terms of billing happens, and this is a reaction to that?
Actually, standardizing the rates is, as of course Mr. Sharma has mentioned, the Act, by the way, Act doesn't mention anything about the rates. Original Act, which is the Clinical Establishment Act, but the rules which were framed later on in the 2012, they only say one thing, that central government along with the state government, along with the state government means that they also realize the rates will be different from state to state, and within the state also district, towns and tehsil will be different. They realize that. Over and above, it says the range. That means range procedure rate can be letting 100 to 150. So that means the top hospital may charge 150 and somebody else will charge 120 and somebody will 100. So that provision is there. And let me tell you, as an industry, we have given letter to secretary only yesterday that we have no problem if in case the costing exercise is done. Now, let me tell you, in this country, we have never done any costing exercise till date. Now, costing exercise means activity-based costing, what is done in the healthcare world over. It is not very easy. It is definitely a complex procedure, but Institute of Cost Accountant of India is available. In fact, the government can give the task to this institute, let them carry out the complete costing. Based on that, if I can assure you, even if you apply that formula in the government hospital, because the costing which Supreme Court, somebody has said 10,000 rupees, it is not 10,000. 10,000 actually is very, very subsidized. If you do the costing based on the fixed cost of the hospital, variable cost of the hospital, subsidy they get, free electricity at the lower rates, so all these things are available in the government hospital. I can assure you the cost of government procedure will be the same what actually my friend in Akash Hospital is charging. It will not be different. It means sometimes we have known that cases that cost in the government may be higher than what is in the private. So in principle, we have no problem. Let the costing be done on the scientific basis.
No, that's a very good point, Dr. Gyani, which you bring out. And viewers, just to add to this, and we'll try and bring Mr. Sharma back if his network permits. But what is Dr. Gyani saying? That look at the healthcare expenditure by state governments and the central government that is provided to government healthcare facilities, land, so many other sort of indirect benefits that are not visible, and that is why the government hospitals are able to show this so-called lower rate. But if you were to do item-wise costing, Dr. Gyani is saying that there won't be too much difference. Let me come to the practicing doctor, and Dr. Chaudhary, thank you for taking time out. I know you have a busy surgical schedule, but is standardization a remedy, or will it be worse than the cure if it is implemented in the manner that the petitioners are seeking?
Well, the moment I got to hear this news, it is quite demoralizing for the private healthcare to, find out that, hospitals ranging from a 5-bedded nursing home to a 1,000-bedded Medanta like hospital are, valued and regulated and standardize as per the rates on the same platform. So that's something which is not a sustainable thing. I do understand it's a every citizen's right to have the health, but if we are comparing both the hospitals at the extremes at the same rate, it is very difficult to be very sustainable in private healthcare. Every year we see the escalation of the basic needs like electricity, water, property tax going 4 times. Now any private healthcare organization is rated at a factor of 4, which has been revised by the local authorities. So the very rightly pointed out by Dr. Girdhar Gyani, there was one study done by FICCI where they pointed out the cost of various procedure. To our surprise, even the costing at AIMS would be almost comparable, if not more, than what any good private healthcare organization is offering. So, if we actually go down to that level, you'll find that in fact the government will see that private healthcare is working at a very efficient manner because they don't linger on the treatment. They start the treatment within no time, and they want the patient to go back home at the earliest so as to reduce the burden on the healthcare system, and they start recovering back at home. So standardizing on a CGHS rate would be a very difficult scenario for private healthcare to survive. I think it has to be looked at holistically, not just that passing on the benefit to the citizens, but at what cost? If we are working on a CGHS rate, and how do we reimburse all our basic needs? How do we reimburse to all our consultants who have got 20 plus years of experience, and they dedicate 10 to 12 hours every day to the organization and for the treatment of patients? It becomes very difficult to sustain beyond a point. And then what is going to happen? Gradually, the things are going to falling apart for private healthcare, which is responsible for more than 70% of the healthcare need, what the Indians are, going to. So I think this has to be looked at very rationally. If we do the costing, I think everything will be transparent. Government can decide what kind of profitability a healthcare organization should get, even if it is 10%, 20%, whatever is legitimate. I think that should be allowed. And rest, we are very happy to work at a basic minimum profit so that we are able to sustain and able to grow at the same time.
Dr. Chaudhary, one of the things that is said about private hospitals is that they overcharge, that needless unnecessary tests are done, that doctors come in, senior consultants come in when a patient is admitted, that billing is also added, unnecessary. And this is something that even the insurance industry complains about, and that they have also taken a stance in this regard. Is this a generalized problem? What would you say to our viewers?
I would say that it's a fragmented problem. Yes, there will be few acts of incoherence in the private sector also, but by and large, any private healthcare organization would not be going to a extent where these things become very common. But these days, patients are very involved in the treatment. We have to do the regular updates, even the clinical as well as financial update on a daily basis. I don't think any private healthcare organization is following this route of overcharging every patient. They are going to be sustainable in the long run. I can only say that there are black sheeps everywhere, but I would say by and large, every healthcare organization wants to order the minimum test and get the treatment at the lowest cost possible. Yes, the only challenge I feel is the communication happening between the healthcare and the patient and their attendants. That has to be strengthened more, because what is the realistic treatment goal? How much time? How much money? How much realistic outcome is expected out of a particular treatment? That something has to be we hardly spend more time on that. I think if we are very well connected with the patient and the attendant, and we update on the financial and clinical aspects regularly on a daily basis, that gives us enough confidence with the patient.
I will come back to you to relate the international experience, because you have international operations also. But if Mr. K.K. Sharma is able to hear us, Mr. Sharma, respond to that. Dr. Gyani and Dr. Chaudhary both are saying that the private sector healthcare will sort of go into doldrums if this kind of standardization were to be pushed through, at least people who can afford it are getting health care. In government sector hospitals, you don't even get access. So why push with this agenda, Mr. Sharma? Already as far as EWS is concerned, or those who cannot, there are various schemes. Central government runs a yojana, states also do this. So why push it on the thing that is working?
No. Let's understand, we are raising a bogey which doesn't exist. First of all, as first speaker told, that government hospitals have got a lot of advantages, free land, electricity, and all those things. Let's understand, most of the big hospitals are societies or trusts. They get free land. They get all things subsidized in the beginning. In the beginning, when I get these things, they go for exemption. It is on the basis of a promise, we'll be providing a service. I leave it to them, look into their heart, how much service is being provided. I'm not saying officially there is some EWS quota and all, but how much is being done, this is a separate story. Number two, whether the service centers will come down. No. First of all, the Act itself provides various categories of services and categorization. Number two, what the government is saying right now, the rates have to be determined. They have not been determined by the central government yet. So when they determine, they will take all these factors into account and they will ensure that all these private sector health facilities are viable. Please rest
No, Mr.
assured,
Sharma, is there a global example? Is there a global example of such a range of costs being determined and standardization between healthcare provided by government and private being done? Where is it happening in the rest of the world?
I would have reacted to it. I will withhold for the very simple reason, NPS of UK and this USA, as of now, there are some problems. So if I say anything, somebody can immediately jump and they say that their conditions is not good today.
No, but since you mentioned UK, wait a minute, Mr. Sharma. I have known your work for almost 2 decades now, and I respect that, but I have to ask you this. It takes 6 months or more to even get a basic appointment in the NHS in UK. In India, you can go to a private sector. Again, affordability is a point. But when Air India was with the government, no, Mr. Sharma, when Air India was with the government, they were offering fares which were supposedly the lowest. But it was a huge government subsidy that was being borne by the taxpayer. How can we make this argument that the private sector should do what the government should be doing? Keep them distinct.
No. Let's understand. I told it I would not be drawn into international comparisons because there are weaknesses there which I do not want to get into. What I'm saying, in Indian context, this CGHS rate, or there are many rates which all these private hospitals on a commercial basis, there's no charity.
Sir, those who access CGHS healthcare, if you hear their stories, they are horror stories. Just in January, I had to access a government hospital in Switzerland, and for a simple X-ray and CT scan, I paid 90,000 rupees, sir. So I don't buy this international argument, Mr. Sharma. With due regard to you, I say that this is a flawed approach.
No, I'm saying I'm limiting right now to the clinical association in India. Talking of the country, because that will confuse at the moment. This act has got enough safeguards to ensure that all the hospitals remain viable, number one. Number two, as an interim measure, what has been suggested, it has not been done yet by Honorable Supreme Court. In case Honorable Central Government is taking some time, as an interim measure, a rate which already is acceptable.
No, but why should center private healthcare, as I understand? Dr. Gyani, please come in on this. Private healthcare, as I understand, is administered by the state governments. Why should the center be the one who should be bothered about this? Shouldn't the Supreme Court involve the states as well?
No. As a matter of fact, if we refer to Article 252 of the Constitution, it provides a provision if 2 or more states think it appropriate and their house legislatures pass a resolution and it requests the union government to pass a law which will be applicable to them, the union government will pass a law. This is that law which has been requested by Mizoram, Himachal Pradesh, Assam, and Arunachal Pradesh. 4 states requested the central government, and then this law was enacted in 2010. So this is, the health is on a state subject, but on the request of the state government, it was passed. Now the irony is that after this law has been passed, rules have been notified, but even the states which requested, there also it has not been put in force. And for that, central government was supposed to determine the rates. That's where the delay was happening. But what I'm saying is that the large number of hospitals in different states which are very happy, there is no murmur on accepting the patients as CGHS rates, which are negotiated on a large basis, which do take into account the cost factor. And CGHS rates are revised over a period of 3-4 years, and they are acceptable. So these
Okay,
rates reflect the cost.
let's hear Dr. Gyani respond to that, because he had also made this point about costing. But Dr. Gyani, respond to what Mr. Sharma is saying, and then we'll continue. Dr. Chaudhary, on can also come in on Mr. Sharma's points. Dr. Gyani, to you first.
Yeah. Actually, let me tell Mr. Sharma, actually, I have been involved in drafting of the Clinical Establishment Act right from 2009 when I was Secretary General Quality Council of India. You see, even in case of CGHS, how the rates are fixed. The rates are fixed by inviting tenders. And different hospitals put their own rates. Small hospital puts middle size, big size. And then more or less on the L1 basis, the rates are fixed at the Ministry of Health. This is never done anywhere. This costing of CGHS rates is never done on the scientific basis. So we are going to actually represent it in Supreme Court. We are already filing the, in the case tomorrow, that even if you want to put CGHS rates, let it be done on the scientific basis. We have really no problem. You just do the costing on scientific basis the way it is done, which is known as activity-based costing. I can assure you the cost will come close to what actually being charged from the hospital at present of time. Number one. Number two, you see actually I have done one small study in the Delhi hospitals where I wanted to find out what is the government spending on per day, per bed basis in the general ward, just general ward. It came about 8,500 rupees per day per bed in the general ward. When I mentioned to the health minister of Delhi that time, he was not convinced. He says, no, it is around 2,000 to 3,000. Then he went back, got it checked again, and he came out that yes, it is actually more than 9,000 rupees per day per bed. But so what happens when patient goes to government hospital, it is free. When it comes to Akash hospital, let us say for 3 days, he charged 30,000 rupees. He say, oh, too much. Actually, I have told state government, next time you start billing the patient, generate the bill for 3 days, 3 into 8, 24,000, subsidy 24,000 minus 0. So, at least people will start realizing what is the actual cost which is being spent by government on them. And then they can compare what is being charged in the...
Dr. Gyani, I want to interrupt here. While, this is a debate and perceptions, emotions are also involved, but isn't there a question that gets raised as far as private sector is concerned? Shouldn't the private sector have also been pushing for a regulator for the healthcare sector? For some amount of consumer complaint resolution, some sanity, because that is the other side of the argument, sir.
I tell you, I have recommended in personal capacity as well as the official capacity, like we have TRI, like we have IRDA, like we have Food Safety Institute of India, let there be a independent regulatory board governing hospital. There is nothing wrong. In fact, it will be good for us. Because at this point of time, adhocism is going on. Clinical Establishment Act, by the way, you should know, only 10 states have adopted, and there also implementation is virtually zero. Because I can tell you, pushing regulation by the government is very difficult. It is never done because they do not have resources. For example, in Delhi, there are 700 nursing homes. Do you think any regulatory body of Delhi government will be able to inspect them on regular basis? You raised one question, small question, I will tell you that sometimes additional tests are being done here, there. The ideal way is do the prescription audit. Just on sample basis, let us do the prescription audit of the hospital.
Mr. Sharma, will this lead to Inspector Raj? once again, because the point, who will micromanage this?
I want to address to Dr. Gyani. Now, he says CGHS rates are never decided on a scientific basis. They have been in existence, in my knowledge. I have been a beneficiary for more than almost 3.5 decades. They have been in existence for 5 decades. All these hospitals throughout happily accepted the present system. Now, just because this petition has come, suddenly are they discovering that these rates were unscientific? Nobody prevented them from going to either whichever court and complain that this is not a good system, and government could have come with a better system. The very fact they were happily accepting, and there was a big competition. Now, I understand how much hospitals try to get in the CGHS panel. Sometimes they complain that payments are not being made, but they were very happy participants. Now, just because there is a possibility of there is some kind of capping and there is some kind of element of check on profiteering, now suddenly we are discovering a system which we have enjoyed for the last 5 decades that no, it is not scientific. Does it not mean a knee-jerk reaction? Does it not mean that there is something else?
Let me answer immediately.
For last how many 4 years, this petition was pending. Everybody was happy, and this was not being implemented. Now 12 states have adopted act, but it has not been implemented. Why it has not been implemented is a big question. I will not make speculations. It has not been implemented because of some vested interest, as simple as that. So then it was no problem. Now, just because there's a possibility of this law taking some kind of breathing into it, so we are fearing and we are coming up with these things. Why they are planning to get implement now? Why did it not come up before? So I would say all these reasonings and logics are good, and we'll see in the Supreme Court how they are raised. We'll come with a counter, but these are being raised now as I would say, as an afterthought. And,
okay, let Dr. Gyani respond, and then I'll go to Dr. Chaudhary.
Just half a minute only.
Yes.
You see, from CGHS, once you are on the panel of CGHS, you automatically get impaneled on various PSUs. So that is the one reason hospital will like to go on CGHS panel, number one. Number two, from CGHS, we get around 30% patient, while 70% patient come to us with the cash and with the private insurance. And for the cross subsidy, we are able to manage. But if you now tell me that 100 out of 100 patients will come at the CGHS rates, I can assure you, no hospital will be able to sustain, particularly the tertiary care hospital. This is I'm telling you today, I was part of government. So I'm not speaking entirely for the private sector. I have spent all my time in government. So we have to be very logical that there has to be balance. We are ready to do CGHS patient 30%, 40%, because that is also our duty. But at the same time, to have financial sustainability, we will have to have patients coming to us from cash and from the private insurance who pay us at our rack rates. So again and again, I am telling you, please get this costing done on scientific basis. We will have no problem.
Okay. Dr. Chaudhary, I want you to relate the international experience. Particularly, you also work in a poorer economy, really, in some ways. And viewers, ponder this thought so far from the debate. This argument, can it be extended to even the hospitality sector, not the healthcare sector? Why should you have 7-star rooms? There also there should be some price control. But but Dr. Chaudhary, the international experience.
So, I mean, about the point on hospitality, imagine, because Taj Mansingh is on a lease rent, is it possible to have 10 to 20% room allocated to the poor and the lower socioeconomic status? I don't think so. So hospitality works on that thing. As a health, is a right for everyone. Yes, we do understand right from the day we started our medicine career. We have to have the empathy, and the cost factor comes later. We have to save the patient's life, and that's what we have been trained all our life. But if we have to run the facility, we have to run the hospital, we at least want to meet the ends. We have to stay afloat. That's the only thing. We are not looking at great profiteering from hospital and buy homes and luxury items for that. Talking about the international thing, we are very regularly getting patients from all across 44 countries, even from the developed countries of Europe and America, and they are surprised to see the quality and the swiftness with which the Indian healthcare is operating. And even at the cost, it is 1/10 the cost of what the patients pay outside in Turkey, in UK and America. So we are already, if compared to a global standard, we are very economical. Now, very rightly pointed by Dr. Gyani, it is a mix. Cross subsidy, we can still survive. Even today, every hospital jostle to get a CGHS panel. Yes, they want a good footfall. They want to serve that part of the community. But once we have that, only then there is a rules regulation. Once we have CGHS, then we'll have rest of the 10 or 20 other panels. So that's a mandatory requirement. But we have seen examples in the past where somebody has gone up to 80 to 90% of occupancy by CGHS. Those brands have ceased to exist. In last 10 years, we have got three similar hospital chains who could not survive because the credit was so much and the payment schedules and the deductions are so high that it's not possible for a hospital to maintain the cash flow and stay afloat, because doctors will be on salary, and imagine the three times or four times you are having a revision of the minimum pay for all minimum wages, and the costing, overall costing inflation. So all these things gives us keeps us in a tight spot. We have to manage in a way where all the other things are also managed with the CJs. One important factor, if a particular this rule gets applied to a hospital who is maybe a 20-bedded nursing home done nicely, but they don't have a CGHS panel. They're already planned the facility for private patient. How can they survive even if it's a 20-bedded, or suddenly shifting, even if they don't have CGHS panel, they will shift entire thing from a private to a government rate. It becomes very difficult, especially for those 700 nursing homes, small nursing homes, to survive just by making all 100% patients go on a CGHS rate.
Okay. Mr. Sharma, I wonder if you want to quickly respond as we wrap up. We are completely out of time, but a quick 1-minute response before we close the debate.
I'll just, in 1 minute, I'll respond to both, to Dr. Akash. First of all, luxury is not a fundamental right, but right to health and right to life is. So there's a difference. Let's not compare 7-star hospitals and all. Coming back to Dr. Gyani, as a matter of fact, this is not the forum. The prices of CGHS is being suggested as an interim measure, not as a final measure. The rates which will be determined by central government will be certainly on a scientific basis, will take viability into consideration. That will be a forum when all of them and such kind of hospitals can go and represent and give their cost structures. That's perfectly fine. So we need not worry, we need not fear. It is only as an interim measure in case central government does not come up with the rates. It's possible central government will come up with the rates, and those rates will be viable rates. They will not necessarily be CGHS rates, and in which all the stakeholders will.
Okay. Dr. Ashish, you wanted to come in quickly, please.
Only my contention is, yes, central government, we will be very happy if they do a scientific exercise to get the rates. But imagine if that exercise takes 2 years for the central government to come up, or 1 year. Still that time, I mean, cash flows, maintenance in private is not beyond 3 to 4 months. That's how things are, priced at this point. If we get this decision after 1 year, I don't think 80% of hospitals are going to be there to serve that, rate to the citizens and their neighborhood. That's my challenge.
This debate, viewers, could have continued for another hour because it is a nuanced debate. The petitioners have a point to make. The private sector healthcare industry in India has a point to make. And remember, this private sector healthcare industry is not just serving Indians, but it is also serving many people, hundreds and thousands of people from overseas who come for healthcare, whose countries lack even basic healthcare. So the question of can everything be priced at the same level in healthcare, as Dr. Gyani has also told us, and Mr. Sharma will continue to litigate, will be decided at the Supreme Court. We can only hope that ideology and the concerns do not create a situation where what is working gets broken. And as I leave you, let's bring up the stock prices of many of the healthcare listed stocks that have reacted very adversely to this news, and that tells you, the red on the screen for many of those stocks tells you that there are significant serious worries. Healthcare business is not child's play, and as we know, a good hospital, a good doctor is the difference between life and death. And we hope that everyone in this argument is on the side of life and good healthcare. Dr. Chaudhary, Dr. Gyani, K.K. Sharma, thank you very much for your time today. Viewers, if you have a response to this, questions that you want to continue to ask, we'll try and revisit this debate in the future. Do provide your comments where you can below this link, and I'll see you again on another episode of Easynomics next week. Until then, goodbye.
Darwin Platform Group of Companies is one of the fastest growing diversified Indian conglomerates with global footprints. It is setting up offices globally and tying up with companies across the globe from multiple sectors. The company has ventured into real estate and construction, stockbroking and finance, arms and ammunition, mining, airlines and many other sectors.